So this talk is sort of an iteration of a talk I give for the residents, for faculty at the floating, but I know that most people that come to the NEQA conferences are really outpatient mainly. And I think what's really important is that what we fail to recognize sometimes, especially in pediatric palliative care, is that this really needs to start a long time ago. The concepts of palliative care, especially in kids with chronic diagnoses, are really not brought up until actually frequently when I meet them in the ICU. And that's really not a time when a family feels safe, stable, or connected to the healthcare providers that they're working with. And so I hope this is helpful to sort of help everybody get into the game early enough that we're not missing the boat. And I think my point always to the house staff who always think that they should call me when a family doesn't want a DNR, but they do, is that that's not what this is about. It's not about making a family agree with you. It's about making sure that we're all working together to find out our goals of care and get to them in the best way possible. So just to start off with some definitions, palliative care is really any form of medical care or treatment that concentrates on reducing severity of disease symptoms rather than striving to halt, delay, or reverse the disease process itself, or provide a cure. It's from the Latin palliare, to cloak. And so it's really to cloak the signs of illness. It can be administered concomitantly with life-saving or curative treatments. It can be initiated at the time of diagnosis or late in the diagnosis or progress of the illness. That's actually particularly important in pediatrics because in the state of Massachusetts, there is a law that children may be under the auspices of hospice care while still receiving life-extending or possibly curative treatment. So they can be in a phase 1 study and still be on hospice. And that's an important difference between pediatrics and adults that is sometimes that people aren't aware of. It can be, it's not aimed at hastening or halting progress of disease. It's aimed at enhancing the quality of life of the patient, the quality of the interaction between the patient and the caregivers, and that is the parent caregivers and the family caregivers, and also the healthcare providers that are the professional healthcare providers. It's not only appropriate when death is inevitable, but when symptoms of illness are difficult to control, quality of life has been adversely affected, or family or patient distress is present. In a scenario where prognosis is uncertain, certainly, and illness complexity and chronicity is likely. So sometimes that's at the time of diagnosis, other times it's later. It's really a lot of it what we do already. Acetaminophen for a fever, ondansetron for nausea. I apologize for all the generics. I always teach the residents they have to use generics. I worked with some British people in my fellowship, and they yelled at us every time we used a brand name. So, morphine for pain, glycopyrrolate or Robenal for secretions, lorazepam, family meetings, social work, chaplaincy, all of the things that we talk about that are integrative therapies. And I always say this guy had it right. Edward Trudeau, cure sometimes, relief often, comfort always. They said that in a time when the first one was pretty rare. And nowadays, now that that medicine has progressed so much, the cure sometimes part has become cure often. And I think that we sometimes lose track of the relief and comfort part of the equation. So what palliative care is not, hopefully, and I think I sort of started out with this, it's not the way to get a DNR. It is really, a DNR is really a very different question than I think people think it is. I don't care about the code status of a patient. Code status really has very little to do with what's really going to happen to that child. What you're asking me when you say, I need you to talk to them about a DNR is, does this family understand what's happening? Are they aware of how things are going to go from here? And do they get it that this kid's not going to survive even if we code him? And I feel like if you get to the point where a child has arrested and nobody knows the code status, you've clearly missed the boat. We have way long ago forgotten to have conversations that should have been had far before this. And so I tend to say, I'm not even going to talk about it. They can be full code. Some families need their kid to die in a code to feel like that death makes sense to them, and that's not my problem or justification for what I do. And the reality of it is I could be DNR right now. I'm not, in case I do something terrible while I'm standing here. But the fact is that any person can be DNR. All you're asking is, by the time your heart stops, do you want me to do chest compressions, give defibrillation, and give code dose medications? It's a very different question than, do you get that you're dying? Can I allow things to happen naturally? Which is a very, very different thing. It is not a bridge to hospice. This is not like a paradigm shift, this isn't working, now let's just go to hospice because clearly you're dying. Palliative care should be sort of on a continuum, and hospice is sort of on one end of the spectrum. It's not the way, obviously, to first approach the topic of prognosis. Families certainly will be very surprised to learn that their child is dying by you bringing up palliative care as an option, or by introducing Dr. Fauman, the palliative care doctor, to the room. It's not a way to avoid talking. I wouldn't accept a consultation of a patient who does not know what their disease process is and what is going on already from the primary care providers. That just breeds distrust in both me and in the primary care providers in the hospital or out of the hospital. It's not a sign that you're giving up. I think that people often say there's nothing more we can do, and I try to concentrate on the idea of aggressive palliation when a child particularly is nearing the end of life, and one group of doctors could possibly say, there's nothing more we can do, we have nothing more to add. When in reality, you may be doing much more aggressive care, you may be providing much more significant duration of nursing care and intensity of nursing care. And it is not a topic best most effectively or most appropriately broached by the subspecialist or the consultant. This is a topic that needs to be brought up when someone who trusts who the family trusts sees the signs and recognizes that it's time to talk about it. Hospice is a different term that is often confused with palliative care. And for most purposes, it's distinct in its resources, its meaning, its timing, and its administration. It refers really to care administered at the end of life, and for insurance or Medicare purposes, it means when life expectancy is less than 6 months if the natural course of illness were to take place. That's a really hard thing to do in pediatrics because we never know. 6 months is, I was just having this conversation before the talk, that in an adult with CHF or pancreatic cancer or several other diagnoses, there are scoring tools, there are lots of statistics. If you have a child with chromosome 2pq deletion and cardiac malformation and restrictive lung disease, nobody knows how many months that child has ahead of them, and it may come down to a sentinel event. Children on average, because of that in large part, enter hospice less than 4 days before their death. And most of the children who die in the US die in an ICU in a tertiary care facility, and that's on the order of 90%. And I don't always know if that's our failing or if that's a success. In some ways, I'm an intensivist by nature and by training, but in some ways, I find it sad to hear that we're not having those conversations so that kids have the opportunity to go home. I think we do a great job of providing end-of-life care in the ICU and on the floor in the hospital when we need to. But if we were able to be honest with our families, not be honest, but be clear with families earlier, I think we would give them the opportunity to feel comfortable going to be at home if they wanted to. It's all in the timing, right? So my patient could die of anything, toe osteo for all I know. How do you know when you're going to bring it up? And that's sort of what I was saying before, that a lot of these kids have such complex illness that you don't know what it is that's going to cause it. It's probably an aspiration pneumonia for some kids, but you don't know for sure, and you certainly don't know when they're going to aspirate, and you certainly don't know when they're going to need to be intubated and have the conversation. And so it really comes down to trying to figure that out ahead of time. And one very helpful tool is the ACT categorizations, which is it doesn't actually stand for ACT, it's like the Association for the Care of Children with Life-Threatening and Terminal Illnesses, which they somehow came up with ACT for. But the ACT categorizations help to categorize the type of illness a child has into 4 categories that might help you to determine when the timing is appropriate for providing palliative care or offering palliative care. So ACT Category 1 illnesses are life-threatening illnesses that may be cured, where curative options and treatments are available, but they may fail. These are things like cancer, leukemia, and there are appropriate times for consultation are usually at times when prognostic uncertainty exists or when cures become impossible. So, ALL, which is relapsed. Otherwise, ALL has an 80% cure rate these days, and so it would be a little bit weird for me to meet them at their first clinic visit, right? But there are other cancers that may be curable, but the cure rate is incredibly low, and it's reasonable to start discussing those things just to plan ahead in a gentle way early on. ACT Category 2 conditions are sometimes actually a continuation of Category 1 conditions. They're conditions where there are long periods of intensive disease-directed treatment, but treatment is going to fail and premature death is going to occur. And all of those treatments are aimed at prolonging life. So this is now, in the adult world, it would be akin to something like breast cancer that's metastatic. There are long periods of time where patients are without symptoms, but eventually they will succumb to their illness. And palliative care is really appropriate early in the course with an increasing role as time goes on. And so this is sort of the pattern that we see in most of the palliative care charts, where you talk about curative treatment and palliative care, and that over time they do this, so that at some point in the illness there's a crossover where they're both almost equally present in the care of the patient, and as time goes on and their illness progresses, they become almost entirely palliative care patients. ACT Category 3 conditions are progressive conditions where treatment is entirely palliative and may extend over many, many years. Palliative care is appropriate possibly at times of diagnosis. This is some of the illnesses like SMA, neurodegenerative diseases. Some of those, it might be appropriate at the time of diagnosis. And I certainly have patients in my practice that are of that type. Or as illness and debility progress and there become choices that need to be made. Does he need a G-tube? Does he need a trach? Is this something that we should say the word need for? Or is it something that we should talk about very carefully and be cautious with the terminology? There are a lot of metabolic and storage disorders that fall into this category. And most of those illnesses are ones that you actually probably won't see in adulthood, right? So most of these children die before they reach real true adulthood. But some of these diseases are ones that we have made progress in over years. And things like Duchenne muscular dystrophy is a very specific one, and we'll talk about it more later, but that's one of those disease processes where we used to think that they all died in childhood, and now we're dealing with a group of young adults who have reached the age of majority, who are still living with this illness. And they represent a sort of funny and difficult group to sort of suss out what to do with. The ACT Category 4 kids are the biggest group. These are the kids with irreversible but non-progressive conditions. These are the static encephalopathy kids that cause severe disability and susceptibility to health complications with a likelihood of premature death. And I don't think we say that very often. But kids with severe cerebral palsy and mental retardation who are bedbound, who do not have control over their muscles, who have, by virtue of their spasticity, have restrictive lung disease from scoliosis. Those kids do have progressive health problems over time. And while we don't necessarily say it out loud, it is a reality. Palliative care is really appropriate at times of decision-making regarding interventions, at times of sort of starting to show the dwindles and increasing complications. And this group represents, as I said, the biggest group of the ACT categorized diagnoses. And it's actually thought that for the most part, and I say here, call me when there are things to make a decision about or when there's been a sentinel event or the dwindles. Because if I were called about all these kids, I wouldn't be able to help any of the ACT 1, 2, and 3s. Because there just is such an overwhelming need. And when it really comes down to it, nobody knows how long some of these kids are going to be surviving with their illness, and nobody knows when they're going to have their health complications. And so planning ahead for all the inevitabilities is really almost impossible for the palliative care doctor to do. But it isn't impossible necessarily for primary care to do. So I'm going to pose a couple of questions. Tell me what you think. Do you believe that children with Duchenne muscular dystrophy are likely to have a normal lifespan? Does anyone think they do? No. What about children with cystic fibrosis? No. What about kids with progressive lysosomal storage disorders? Probably not. What about a kid with a severe static encephalopathy? Probably not, right? And what would you tell them if a parent said to you, will my child with Duchenne muscular dystrophy have a normal lifespan? Will my child with cystic fibrosis have a normal lifespan? My child with progressive lysosomal storage disorder? And what about severe static encephalopathy? If they asked you that question straight out, if they really asked you like in those words, I think most people would probably say, well, no, let's sit down and talk about that. I'd hope that that's what most people would say. But the fact is that most parents don't ask that. They don't say it like that. They just kind of wonder it, and then they just go on with their business day by day by day until they're faced with decisions to make. And then each decision just becomes a step and becomes another phase or another stepping stone on the road. And we don't ever really directly address that from the get-go in a lot of cases. And so what do you think they would tell us? If we polled parents of each of those kids, how many of them would say that a doctor has compassionately told them that their child's lifespan will be limited? How many would say that a doctor has not compassionately told them that their child's lifespan would be limited and then said that that doctor is no longer their doctor, right? Someone told me he was going to die young, and they were such a jerk that we never went back because we have hope and because we know better, because he always beats the odds, because he never reads the textbooks, and because he's different than every other kid with this illness. He's defying the odds, right? And that's a common story. And so that's why everybody's afraid to say it, right? Because you don't want to be the doctor that said it and then we're wrong and then the family hates you. But it came down to probably, I'm guessing, how that conversation went. And a lot of the time, when I'm the bearer of bad news, I expect them to hate me, and really, they don't. Even the ones that I really think are gonna. And I still think that, even now, but it really isn't always how I expect it to go. And how many would say that a doctor has compassionately told them that it would be limited and then said that that doctor is no longer their doctor? That's rare. None of them have that recollection. And it's all about your experience, obviously. You know, did you experience it as compassionate or not compassionate? But in reality, they're not going to be angry with the doctor who knows them, who they trust, who is saying to them compassionately, your child's not going to have a normal lifespan, and we need to talk about what that means and how we're going to plan ahead so that we don't get surprised by things, and so that we have something in place to help us make decisions so that we don't have to make them in times of distress. And how many of these parents do you think would say that their kid's lifespan is actually limited? Even if they've been told by someone compassionately, it's hard to say. Some of them will not state it or verbalize it. Some of them know it, but just won't say it out loud. Some of them just deny it until they're faced with something that forces them to believe it. How many of them do you think will say that their child will have a normal lifespan? And would you think those parents were crazy, or misinformed, or hopeful, or faithful, or reasonable, or maybe all of those things? And all of those things have crossed my mind, right, when I hear that from a parent, and I go back and try and hear the conversations that they must have had. The child who spent months in the NICU, and the parent now says to me, oh, 98's a fever for him. He never listens to the rules. Yes, he does. Every child listens to the rules of physiology. We all do. The question is which rule they're following. But what really happened is many years ago, someone said, I don't know, he always doesn't listen to the rules. He's different than everybody else. He just defies the odds. And while we think those are hopeful statements and helpful statements, what we're really doing is setting up distrust between the medical system and the family in a situation where what they really need is a long-term relationship with us that we have to foster in a way that doesn't make us have to explain everything. We might be able to just leave things open and help them plan for things that may or may not be inevitable.
I think the compassionate, or being compassionate with the patient, I think is not the difficult part.
Yeah.
I think the difficult part is the timing. You know, when really to address it. Because, you know, for example, a patient who's born with cystic fibrosis, you're going to tell from the beginning, okay, this is going to be, so I think the most is when is supposed to be the right time to address this, and then when it has been, someone has addressed this. You know, I think the parents will hate that everyone now is telling me this every time. So we're hearing this over and over again.
That's why I'm cautious not to do it a lot, actually. You need to do it once, and you need to make everyone aware it's already been done. I don't actually agree that you can't do it at the very beginning with cystic fibrosis. I think that what's important is that you allow the family to know, you send your warning shot. We need to have a difficult conversation about this. And I always tell the residents, if you're struggling to figure out what words to use, just stop, take a deep breath, and say what you mean. If you are trying to figure out how to say it, just say, we need to have a conversation. why don't we set up a separate time for you to come in so we can just sit and have a conversation together, a normal conversation about how things are going to go and what this means and what this diagnosis means in the short term, in the midterm, and in the long term. And if they know that's coming, it doesn't feel like a surprise, and it doesn't necessarily feel like a threat. And I think that is how I usually tell people to handle it, is to just be very clear that that's the conversation you're about to have, instead of sneaking it in there. Because if you sneak it in there, they're going to feel blindsided. And if you say, we're going to set up a separate time for this, we need to have this conversation now, and we may readdress it in months or years or days or weeks, depending on the situation, then generally I think they're pretty receptive to it. But it does depend, and you're right. I mean, I don't do it for every kid with asthma, right? So how do I know to do it for CF? CF is one that I think we know. We have data on CF. But what about, an unknown neurologic disorder? What about a kid with cerebral palsy, which is moderate to severe, who has a G-tube but not a trach? I don't know. I mean, it's tough to know. And you have to feel out each family, and you have to know them well. And I don't know them well, right? I mean, I meet them when I'm consulted or when they're in my ICU. And they're more receptive to things then because they see what's happening. But it doesn't necessarily mean that they want to hear it from me, right? Does that answer your question? Okay. And I think, like you said, what makes it so hard, as the primary doctor, your relationship really may have been changed by increasing acuity of illness over time if this is later in the illness course. And healthcare utilization separates the patient from you. And you usually don't feel it's your place to discuss the subject of long-term prognosis in a kid who has subspecialty problems, right? This is a cardiac patient with an inoperable cardiac problem. Clearly the cardiologist has to tell them about that. And that may be true in some ways, because in a lot of these kids, especially like oncology patients, it's almost like the oncologist becomes the primary care doctor, and they're like giving immunizations. I mean, they're doing everything, and the relationship is very different and very intense, and you feel like someone's sort of stolen your family in a way. But there are other patients where it's much more appropriate coming from the primary doctor. Sometimes you don't actually know the long-term prognosis. I think that's very much the case when it's a very subspecialty-oriented diagnosis, especially in a place like Massachusetts, where I am shocked and amazed at how quickly patients have like 3 or 4 subspecialists. I came from Michigan, where we were kind of the only show in town, but there were community patients who never saw a subspecialist, and their CF was managed by an adult pulmonary person in the UP, which I'm not saying should happen, but it was interesting. It's interesting for me to see how quickly patients are sort of farmed out in this state, and it's certainly a different dynamic. And I think sometimes you really have to ask, and I think our residents have to ask us, I'm so confused, why are we talking about this kid's potassium? I'm under the impression that he's dying. And so I think it's a similar question to say, hey, he's coming to see me for his well-child check and he has stage 4 neuroblastoma. What's going on? What is the prognosis here? Just give me a number. Maybe they don't want a number, but I want a number. You don't want to upset the family because, like I said, like we were saying before, you're worried your long-term relationship can be affected in this case. You're not sure what the subspecialists have said beyond the general outlook, and your office-based setting makes it difficult to assess need or observe the child's degree of symptomatology. It's very difficult to predict, like I said before, when a child will die. There are very few diagnoses in pediatrics where there's a very specific timeline. That, in adults we have terminal CHF, pancreatic cancer, COPD, dementia. They all have very specific timelines and scoring tools. There is not a single scoring tool for likelihood of death in pediatric diagnoses, not one that I'm aware of. And I've never been asked for one. It's never occurred to me to ask for one because we always go, all doctors lie about time, and then we just kind of leave it at that. But her parents love her is actually a direct quote from my GI attending when I was a resident, and I believe at some point in the conversation of this severe CP, G-tubed and trached child with intractable IBD who was having electrolyte abnormalities and was TPN dependent and had aspiration pneumonia, I said, do you think maybe we should get a palliative care consult? And the first words out of her mouth were, "But her parents love her." And I said, "Well, I'm sure they do. I didn't think they didn't love her." And they said, "Well, why would you want a palliative care consult?" And I was like, because there's a lot of stuff going on. This kid's probably not going to survive much longer. Don't you think we should address it? And of course, what she was thinking was, well, her parents don't mind taking care of her. She's a complex kid. She's always been a complex kid. Why would you talk about palliative care? That means that you're ready for her to die. Her parents don't want her to die. Okay. Everybody relax. All I wanted to know was whether we were really taking care of her symptoms, because here we were sitting in rounds talking about her potassium. Literally just talking about her electrolytes all day. And nobody paid attention to whether she was in pain, whether she'd slept that night, whether she had any quality of life, whether she'd interacted with child life, whether she'd interacted with her parents. No one had asked. No one had even considered it. And it just seemed logical to me. And I think once I said that, sure, but it's not always intuitive. And most of all, I think that we really just don't ever know where to start, even pediatricians, because kids aren't supposed to die. Grown-ups are supposed to die eventually, right? If you have dementia, it's a terminal illness. If you have COPD, it's a terminal illness. If you have stage 4 neuroblastoma, it's a terminal illness. But no one says it. We just are afraid to, because it's not supposed to be. So where to start? 3 very important ethical principles that are really the mainstays of palliative care. There's a few others. There's the beneficence and malfeasance, but whatever. It doesn't matter. Those are important, but we all get the general concept of those. The first one is, I think, well highlighted by this picture. So I'm sure you can tell that's me on the right, or stage right, house left. I was University of Michigan Medical School class of 2004. I'm actually going to pick up a patient on ECMO on the helicopter there. That gentleman next to me was University of Michigan Medical School class of 1952. Does anyone know who it is? I have chocolate if you know. No. 52? How old do you think I am? How old's my dad? No. Someone who's hopefully going to help me isolate those 2 principles. I actually stole that photo from the class photo on the walls of University of Michigan's hospital's hallway. He's really famous. So he's not my dad, who's not that famous. And he went to University of Chicago, my dad said.
Initials? Yeah.
JK. Who said that? Oh, you get chocolate. Here, pass her this whole bowl. You can pass it all the way back.
Oh.
You can, sure. You can share it if you want. I don't know. Don't go to Sugar Shack. Hope no one's diabetic in here. That's Jack Kevorkian, who graduated from University of Michigan in '52. He's one of our most infamous grads. We have more famous grads. Dr. Bartlett, who invented ECMO, was a graduate about 2 years later, I believe. Several other people who I respect very much. But this is Jack Kevorkian, and we're sitting next to each other. And it's true, we did graduate from the same med school. It's a very dangerous comparison, though. And I use it to illustrate a point, because I worry that there are people that think he's my hero. And that makes my skin crawl. The fact is that the most important principle in palliative care, the thing that I just check in my mind every time I'm not sure if we're doing okay, and if this is the okay thing to do, and if I really just need to call ethics and ask them for their blessing, is the principle of double effect. And the principle of double effect is the set of criteria that states that an action that has foreseen harmful effects, practically inseparable from the beneficial effects, is justifiable only if the following 3 things are true. The first one is that the nature of the act is itself good, or at least morally neutral. So giving pain medication to a patient in pain who's dying has to be morally good or neutral. So there are neutral ones, feeds, ventilator support. Those are actually considered neutral acts, removing those things. But the nature of that has to be one of those 2. The agent has to intend the good effect, or the person, the physician has to intend the good effect and not the bad effect, either as a means to the good effect or as an end itself. That means the morphine is being used for the purpose of relieving pain, not for the purpose of causing cessation of breathing, which would lead to death, which would then backtrack and relieve pain because they're dead, right? And the third one is that the good effect has to outweigh the bad effect in circumstances that are sufficiently grave to justify the risk of causing the bad effect, and that you're exercising due diligence to minimize the harm. So you're talking about a situation where the risk of someone having respiratory depression, which, by the way, there's actually no statistical proof, and there's actually sort of the opposite statistical proof that adequate pain relief and morphine, even in the last couple hours of life, causes increased or shorter time till death, even in patients where you've removed ventilation. The time before death between removing ventilation and death is not any higher in patients who receive morphine and Ativan. That said, it has to be sufficiently important that the risk of apnea is worth taking, and you have then exercised caution in administering an appropriate dose that minimizes the likelihood of respiratory depression. So you're not going in the room and giving 50 milligrams of morphine to an opioid-naive patient. You're giving a dose-based, a weight-based, or in adults probably just a standard dose, and giving it appropriate to the amount of opioid naivete of the patient. Where Jack went wrong, one of many ways, his suicide machine is a lethal phenobarbital dose, which is an anticonvulsant in a patient who's not convulsing, followed by a dose of potassium chloride, which is a myocardial toxin, and a dose of pancuronium, which is a paralytic that causes cessation of respiratory effort, just in case the KCL didn't work. Medication administration is, in this case, for the sole purpose of causing death, and thus presumably ending suffering by causing the death. That does not at all illustrate the principles of double effect. And that's why palliative care docs feel uncomfortable with the physician-assisted suicide laws. In fact, I mean, no one needs to know my political preferences, to be honest, but I feel very uncomfortable with that. And I think that the fact is that if someone were to ask me to write them a prescription, luckily I'm a pediatrician, so it's unlikely, for a lethal dose of Seconal, I would want to know, why is your pain not under control? What are we missing? Why is this happening? And when they've done studies in Oregon and Washington State about the patients that ask for this, since the law was instituted in, I believe, 1998, there have been somewhere around 460 patients that have had it, 460 who have actually committed physician-assisted suicide, or undergone, I guess. And I think there was all this worry that there was going to be thousands and thousands of people flocking to the doctor to have physician-assisted suicide. And really, when it comes down to it, there's a very specific demographic that requests it. It's all old male ex-Marines who don't want anybody else to have any say in their life. And they don't want anyone around them, and they don't want anyone's sympathy, and they don't want anyone to make them lose control over their body. And it makes sense, but I don't need to be the agent of that. And I think that is why it's uncomfortable for people. Now, do I think it's inherently wrong? I don't know. I don't know that I have an opinion formed on that. But the fact is that it's not entirely a spectrum, right? From palliative care to physician-assisted suicide or euthanasia. That spectrum has a sort of a gap in it where a lot of people don't jump the gap. And Jack, he does.
Many of those patients who can give a prescription
Yeah.
for suicide,
don't even do it.
they don't even.
Yeah, about 10% of the patients that
exactly.
Just in case. And it's one of the other things that they suggest doing in cases where people ask for it over and over again in a state, of course, where it's not allowed and you're not willing to do it, is to say, I can give you I can talk about it with you later, but let's figure out what it is in the meantime that you're missing that makes you feel like you need that control. We're not going to take away your control. You need control over your body. I get it. I won't put you in a situation where you have no control. We'll make sure that we keep you comfortable and in control of things. Can we always promise that? I don't know. And in pediatrics, I'm lucky that I don't have to deal with it. But it's a real question. The second more important principle is autonomy. And it's a special case in pediatrics. And I think we also have a misunderstanding of what autonomy is. In fact, one of my residents told me yesterday that something that made me know she misunderstood it. We had a child who came back from an ASD closure in the operating room, and she said, oh, they decided to do it operatively because the parents preferred that over cath closure. And I said, I'm sorry, cath closure was offered, and they allowed the family to decide between them? And she said, well, yes. And I said, why why did we offer surgery if we could have closed it by cath? And I'm sure there was a reason. It was probably big enough that we could try, but we might not be able to, so we should just definitively try surgery. But the response that I got from the resident was, well, autonomy. And I said, no. That's not autonomy. I don't ask you if you want dialysis or ECMO. That's not autonomy. That's a medical decision. And then I can ask you and give you informed consent, and then you can say, by the principle of autonomy, no, thank you. But you can't demand that I do surgery on a patient where something else would be more appropriate or beneficial. And so that's quite a misunderstood concept, I think, frequently. But the special case in pediatrics is that we're now dealing not with the patient's autonomy, but with the autonomy of the parents because they're the proxy. And a competent patient or proxy in any situation, any medical situation, may refuse medical treatments offered to them even if medical opinion believes the treatment will provide benefit to an extent, right? We've all heard of cases where the family refused treatment for their child's leukemia. There was a case like a year ago, I think. And there was there was all sorts of legal proceedings, and eventually they ended up requiring that they treat him because the other parent wanted it. But in general, assuming that the parent is assumed to be acting in the child's best interest, we do allow them to refuse any medical treatment that's offered, even if we think it will provide benefit. Parents are assumed to be acting in the best interest of their child unless evidence exists to the contrary, and that's what really ended up happening in that case, or at least that's what the court system decided, right? But if the child were a Jehovah's Witness, there's lots of case history to back that up. They might not have forced the issue, right? Had they said he has to have blood transfusions for this, it might have been a very different thing. Children are unable to provide legal consent for treatment, but they should be able to provide assent appropriate to their developmental age. So if I have a 16-year-old that's gone through 3 rounds of chemo and has relapsed again and again with leukemia, for example, and doesn't want to undergo a bone marrow transplant with a mismatched donor, for example, and the parents want them to, it's sticky. And I usually will consult ethics. I've been told I can force the child to undergo it. That feels wrong. A 16-year-old who's able to explain to me why they feel uncomfortable, why they don't want something done, and why they're ready to allow themselves to die, is clearly aware of what's going on around them, and they've been through this illness already. And so generally at least I haven't had a situation where I've had to have the conflict become unresolved, is that we have to just sit and say, listen to your child. Listen to what he's telling you. He's tired. This isn't going to work probably. He doesn't want to do it anymore. He wants to be with his friends. It's a rare thing, but it does happen. And almost all of the time, and all of the time in my experience so far, we've been able to resolve it. But it can be the case. And there are situations that make it even trickier. So cultural norms and personal beliefs may make those points a little less clear. And in addition, this situation I've run into a couple of times at Tufts, adolescents, particularly of parents who don't speak the languages of the caregiver, but the child does, present a very special and difficult dilemma, especially when their desires differ from their parents. So we had a child who was acting often as the translator for her parents and was clearly the smartest one in her family, clearly got it the best, clearly understood what was happening to her, and she was done. And then she became unconscious, and her parents couldn't get there. They couldn't, even with an interpreter, because the interpreter even couldn't really say what she'd been saying. And it took a couple of weeks for us to really get them to the place where they understood that this was terminal and we couldn't fix it, and we really needed to stop because it's what she would have wanted. But she couldn't have signed an advance directive before she became unconscious because she was only 16. And those situations become very difficult in kids who are bright and adolescent, and maybe their parents are not as much as they are.
Is there any cases at home regarding these 16-year-old mature adolescent?
Yeah, there's the mature adolescent and the emancipated minor. They're different. The emancipated minor can make their own medical decisions. The mature adolescent is supposed to be listened to.
It's still sticky.
It's still sticky, yeah. I think our ethics committee is pretty good about backing us up when something is, I don't have to say how uncomfortable that made us feel. You guys can all tell how uncomfortable that would be for a 16-year-old to tell you, I'm done, I get it, I'm dying, I'm done, stop putting poison in my body. And for the parents to say, no, keep doing it. That doesn't feel right. I know the parents have right to make decisions, but they also can't force us to do something that seems out of line with appropriate goals of care for the child. establishing competence does require that the patient understand and retain information, believes the information, and can weigh the information presented to them. That does not mean that they agree with the prevailing medical opinion. So what I'm saying is, if you say the MRI shows increasing size of your brain tumor and increasing likelihood of herniation, the family has to say the MRI shows increasing likelihood of herniation and increasing size of tumor. But they can still say, but I don't think that means she's going to die. Even if you've told them that you think that and that you think that you should stop treatment because of it. They do have to be able to understand the logical facts, but the opinions do not have to be agreed with. And autonomy does not require, like I said before, that the healthcare provider meet all the demands of a patient or family if they're not based on medical standard. So a patient is not required to provide chemotherapy for a patient if no evidence exists that it will provide benefit, even if the parents insist. So that leaves open the ability for us to provide, and really the responsibility of us to provide an opinion and a recommendation, rather than saying, here are your options, pick one. And I think we've gotten further away from doing that. And, you know, as I gave a grand rounds on family-centered care, and here I am saying the opposite of that. You can't say to a family, I'm going to give you two options. I'm not going to tell you which one's better. I want you to pick one. Do you want more chemo or no more chemo? Do you want him to try and live, or do you want to let him die? That's not fair. They obviously have only one answer to that. But what you really need to do is say, in light of what's really happening here, this child is dying. I don't think chemo is going to provide more benefit. If it's not going to provide more benefit, would it feel better for you to do X, Y, or Z? I would make a recommendation that we do this for these reasons. And there are cases where a family cannot verbalize it, but they understand it and they want you to do what is clearly right to everybody. But they can't say, I want you to stop treatment. And so what I will sometimes do and have done in the past, I mean, I even had a mom a month or two ago say, his quality of life is terrible. He has no interaction with his environment. He's suffering every single day. He is neurologically devastated and is never going to get better. But I can't say withdraw his feeds. Can you make the decision for me? And I said, do you want me to say that we should withdraw his feeds so that we can allow him to die more comfortably? And she said, can you say that? And I said, sure, right? I mean, she was telling me what she wanted, but she couldn't be the one to state it. And it's going to happen like that a lot of the time with families. And I will sometimes say, I want you to understand that if at this point her heart stops, we're not going to get her back. And the last thing I want is for her last few moments to be with me thumping on her chest instead of you lying in the bed with her. And so I'm telling you now that if her heart stops, that's our sign that her body has given up and it's time for her to die. And we will do everything we can to get your whole family around her as quickly as possible. And we will not perform chest compressions, and we will not provide defibrillation, and we will not do code dose medications. And I have not yet had a family say, are you crazy? In addition, I always add the caveat of, does that sound reasonable to you? Or does that sound really uncomfortable? And they all just kind of nod their heads, right? They get it. They're not clueless. And that's 95% of the time what someone says to me, right? This family just doesn't get it. We need you to talk to them. They get it. You just have to give them something. You can't make them make these decisions. It's not, they shouldn't have that much autonomy because it's not fair. And no one can make those decisions about their child. Misunderstood autonomy. So these are some of the conflicts that we see a lot. They arise all the time. This is when we call a family meeting, consult ethics or palliative care. I've tried since I came to Tufts to make sure that all the consults to ethics about patients are done by me rather than instead of me. Because what we found in Michigan was that as the palliative care team actually became developed over a couple of years, the ethics consults went from 26 a year to 0. And what was really happening was people were butting heads and they said, I'm going to call ethics on you, instead of saying, we need to sit and have a conversation that's logical about this. And so instead of calling ethics on someone, I try to make sure that I find an ethical question that we're debating and I ask a question instead of saying, tell him he's not doing it right. The conflicts that I think we always worry about our parents versus healthcare team, that they just don't get it, I think we already talked about. Just leave him alone. It's actually less common, to be honest, these days. You know, the family saying leave him alone and verbalizing things before we do is pretty rare. You can't take away our hope. That's a pretty common one. And I always address that with, I would never take away someone's hope. I never want to take away your hope, but let's hope for things that we can achieve. And let's try and figure out how we can achieve them best. Don't tell him about his illness. We're protecting him. That's a really tough one. And it depends on the child's developmental age. But there's a good story about this. I don't know if any of you saw this on the Today Show a few years back. I was getting ready for work, and it was Matt Lauer interviewing the parents of a little girl, I believe named Julia or something. I might have to take some poetic license because I don't remember every bit of it. She was 6 years old, and she had died of a brain tumor. And initially, after her diagnosis with the tumor, she had had an initial or primary resection, and she'd lost her ability to speak because it was in the temporal region. And so her parents had resorted to, with her, communicating by notes and by pictures. And she was a pretty bright kid, and she had good motor control, and so she would write them notes all the time. And she progressively got worse and worse, and they didn't tell her that she was sick because they didn't want her to be upset, and they didn't want her to worry. And after she died, they found hundreds and hundreds and hundreds of notes and pictures hidden around the house. In books, in Dad's sock drawer, in the refrigerator, in briefcases, in lunch boxes, in toy boxes, every single location in the house. They would find a note probably once every other day at first, and then they started finding them with less frequency. But at some point, they found 2 letters that were sealed in envelopes, and one said Mommy and one said Daddy. And they were letters, clearly, from her. And both of the parents had said, we're not going to open these because we're scared it'll be the last one we ever get, and so we don't want to find the last one until we're ready. And so they had waited, and they still hadn't opened them by the time they're being interviewed. And at some point in the conversation, Matt Lauer says, wow, so he asks, what are the specifics of the pictures? Well, there was one with her flying as an angel above the house, and her sister running below, and her going, go, Josie, go. And another that said, I love you, Mommy, I love you, Daddy, I'll always love you, all sorts of very clear messages. And he said, gosh, what a bright little girl. Do you think maybe she knew? And her parents went, oh gosh, I hope not. That must be scary for a little kid. And I just thought, oh my God, that poor child had no idea that she could say something to her parents, and she was protecting them for a year and a half or so, and never felt like she could talk about it with them or message them about it because they were protecting her. And I always tell parents, not only do they know, but if you don't tell them, they think something worse. So I've had 7-year-olds say, Daddy, shut up, I'm dying. I've had probably not younger than 6 or 7, but kids know at a very young age, and even littler kids know when something's occurring that they're dying. They can't verbalize I'm dying, but I've had 3- and 4-year-olds spend the last 12 hours of their life saying, I love you, Mommy, I love you, Daddy, over and over and over and over again. And they clearly know something's changing. And the idea that we should protect them from the facts at an appropriate, developmentally appropriate level is unfortunate. And we've done them a disservice in a lot of those cases. You have to do what we say because we're as parents, well, I think we've talked about that one. We don't actually have to do what they say. A parent cannot order you to do CPR. A parent cannot order you to place a tracheostomy if you don't think it's appropriate. If you feel like there's a conflict like that and it's not resolvable, you can always call ethics for discussion and backup. But they cannot make you do a medical procedure on a child if it's not medically appropriate. And that's something that I think we sometimes forget. Healthcare team versus healthcare team. This is a lot of the time about nursing. You know as well as I do. So you have and the residents will often say, like, this kid's dying. Why are you ignoring it? Why aren't you talking about it? Why are we talking about the potassium? Look, what you're making me do is really a problem for the bedside nurses. They feel sometimes like they're lying. They're sitting at the bedside of this child. They're not allowed to say it out loud. They know that the kid's dying, and the family isn't acknowledging it to them, and so their only understanding of it is that you've never said anything. That's not always the case, but if we're not including them in the conversation, they don't know that. Why are we doing this? It's sort of the same conversation, right? Why are we giving this medication we know it's not going to do any good? And then the do everything, and I had them hand out this essay by Chris Feudner. He's the head of palliative care at CHOP. Very bright guy, and he does very well-designed research on hope, which is incredibly difficult to research. But this is a really, really great explanation of exactly why anytime someone says to me, oh, no, but the parents said they want us to do everything, I go, oh, I have no idea what you mean. Everything. You want me to put him on ECMO? He doesn't need it, but do you want me to put him on that? Because that's everything, right? We've got everything available to us. So why not just do it? Why not just put a cannula in when you're born? Because then we know that we can just provide everything, right? But what parents are really saying is, we don't want you to give up if there's really something left you can do to keep them alive. And so I always ask people to clarify by what they mean by do everything. That statement doesn't mean that you have to do CPR. That's not what they're saying. It's a very surface statement that requires a lot of exploration, and we often fail to do that. Parent versus child or parent versus parent, we've already talked about the mom I'm dying one. And then there are sometimes situations where the family dynamic is tough and the parents may not agree with each other, may not be on the same page, and our job is often to just kind of get them both there. Statistically, what you'll see is that the parent who wants to be most medically aggressive will win. And it's reasonable why that happens, unless that parent is way out in, well, left or right field. Because the fact is that the other parent now, A, has to live with them, and B, has to feel like both of them had had the opportunity to do everything they could to keep their child with them so that they don't have guilt in the future, which can be damaging to their relationship later, too. And then the third one, the moral equivalence, but if we start now. For most situations, and I will say it 1,000 times, but I will also say the caveat. For most situations, not initiating a therapy is the moral equivalent of discontinuing the therapy. It's the same thing, but try telling that to a parent, right? We put in a G-tube years ago, but you don't have to feed through it. Yeah, I know he's had it for 10 years, but you know, it's really morally equivalent if we stop feeds now. Yes, it is, but it's kind of tough to swallow that, no pun intended, right? Sort of. But you really have to talk about it gently and understand that while these things are true based on the bioethics system that we've developed in the United States, that's not an absolute truth. That's what we've decided as a society. And so a parent may not have the same emotional connection to that statement. Just because a child goes home on a vent, though, doesn't mean you can't discontinue mechanical ventilation. Just because a child has a tracheostomy does not mean he ever has to be placed on a ventilator. I have gone down to the ER before to admit a patient where the ER doc said to me, well, he came in from, long-term care facility that won't be named, and he has a trach, but I don't see his vent anywhere. And I said, is he on a vent? And he said, well, I don't think so. Why isn't he on a vent? He's got a trach. And I said, whoa, that's a very different thing. If someone needs a trach to maintain their airway versus if someone needs constant conventional positive pressure ventilation, that's like a whole other therapy that I would certainly hope we would have another discussion about. He goes, well, shouldn't you just have one around in case? Well, I mean, I understand the logic there, but no, no. And in the ER, it's easier for you, probably, yes, but no, don't think of it like that. Please have a conversation before you put a trach in and then assume that the child's going to be on a ventilator. And just because she has a G-tube doesn't mean you have to feed through it. And that was the case with this child in the ICU that I mentioned earlier. That child had a G-tube his whole life. And the parents actually decided to withdraw feeds a lot quicker than I realized they would. It came up as an option, and I thought they would certainly balk at it, because who doesn't, right? And they didn't. They actually said, well, that makes logical sense. Let's do that. His feeds just make him have secretions, and those strangle him. But having a G-tube in place makes it hard to not feed sometimes emotionally. And then the slippery slope of tubes and their attachments, and that's what I was talking about before with the vent. I mean, just because you have a tube doesn't mean you have to attach more things to it as time goes on. As the child gets worse, you have to recognize the change in their disease. And it's one thing for a child to start out on a ventilator with a trach because they have a stable lung disease versus a child who is 15 years down the line with his chronic illness and who now is having issues maintaining his airway and now needs a trach and then now has restrictive lung disease and now maybe needs a vent too. And we start just adding things on at the end of life as opposed to as a stable therapy. And no one has to have a tracheostomy, a home vent, a Broviac, a G-tube, a DJ tube, a spinal fusion, sort of, right? There are cases where that's not the case. The fact that I always remind people of is If you have a terminal illness and this is a treatment for that terminal illness, you don't have to do it. So if you have ALL, you have to have a Broviac. If you have subglottic stenosis, you have to have a tracheostomy. You need it. I would be comfortable saying you need a tracheostomy if you have subglottic stenosis. But if you have chronic, debilitating, progressive disease and you have increasing lung disease requiring multiple intubations and your airway becomes unstable, that does not necessarily require a trach. And saying he needs a trach will make every parent agree to it. But if you say one option would be that we stabilize his airway with a tracheostomy, another option would be that if we don't think that's appropriate for his quality of life, that we say a tracheostomy is not appropriate or acceptable to us. And if you once did have those things, it doesn't mean you still have to. But keep in mind that some of these interventions may be palliative. So a trach can often allow a child to be off sedation and in their parents' arms. A gastrostomy tube may allow a child to avoid discomfort of respiratory distress with aspiration. A Broviac can be used to give pain medicine. A spinal fusion can make a child easier to care for as they grow, relieving caregiver fatigue. But be really careful of over-customization. So I don't let parents say, he's DNI but not DNR. If you are going to get chest compressions, you are going to get a tube. That's it. No, we don't have conversations about those things. We can't do things that are medically illogical, but we can do things that are consistent with goals of care. Make him comfortable but not sedated. Possible for some period of time, but there are often times when we're not able to do that any longer. Understand the reasons people pick and choose. It's not always what you think. I think that there are times when we think that they're not wanting a trach. For example, a Duchenne patient doesn't want a trach because they don't want a trach, and they're willing to die without it, when really they just don't want to have to worry about people seeing it, and we can come up with other solutions. Elena's case is an illustration of this. So she's a patient I actually have had in Massachusetts. She's a 21-year-old female with Duchenne muscular dystrophy and Turner syndrome. So that's how she has Duchenne, even though she's female. She was admitted to the PICU for acute respiratory decompensation, required intubation and mechanical ventilation. She'd previously required BiPAP by mask at night, and now is unable to be extubated due to multiple failed attempts requiring urgent reintubation. She's heard that some patients with DMD need a tracheostomy, but she's never needed one herself and is afraid to have one. Problems here. So she's reached the age of majority just as her disease process has started to significantly limit her quality of life, which is the case for a lot of our Duchenne patients. She's not made any major decisions for herself before because she's been relatively well since reaching the age of majority. Communication and clarification of her goals of care are a little bit limited by the need for sedation while she's on the ventilator. And the third thing that was upsetting was that she was surprised that a tracheostomy was being discussed now since she's been well for a long time and no one's mentioned that she might be getting sicker. She isn't sure why she's in such a rush to decide. Why do we have to decide this right now? Give me some time to think about it. So palliative care consult. She was awakened on mechanical ventilation. Goals of care were discussed at length. She reports that she wants a tracheostomy only if she needs one. And she doesn't feel prepared to face her own death, denied having considered the possibility that she may die. Does not have a close relationship with her current care providers because she's never been into the ICU in the past several years because she's been fine, right? She's been fine. She's been well. She has Duchenne, and she's 21, but she's been fine. She's currently undergoing outpatient transition to adult providers, but hasn't completed that transition yet. And she says that she feels rushed to make a decision she doesn't feel equipped to make. So she agreed to tracheostomy, though she expressed anger at her providers for rushing her in their decision making. I was one of those providers, and I rushed her. I said, no, we really have to make this decision now. We don't have another time to make it. This is the time. 5 days after tracheostomy placement, she requested that her trach be removed because it was uncomfortable, and she just wanted to go back home just like before. Her parents and care providers negotiated a 6-month trial period with her, after which she can still have the trach removed if she so desired, with the understanding that she may not be able to be sustained without positive pressure ventilation. So what could the palliative care doctor have done better? What about the ICU doctor? I'll be honest, I was both. That was a tough position to wear both hats, but we were in a bind. I think what I felt a little bit of counter-transference about at the time was that I felt like other people should have had this conversation a really long time ago, that a 10-year-old Duchenne patient has a very specific future ahead of them, and we have lots of data to back it up. By 21, almost all of them need assistance with their airway, if they're alive. And the fact that we'd never even discussed whether she was going to want one is really tough to swallow when you have to bring it up the first time, because now you're the bad guy. It's fine. I can be the bad guy. I've been the bad guy. But it was almost shocking to me that she'd never even thought about it. Well, I know that some of those kids have it, but I didn't think I would need one. Really? Okay. Well, that's our failing, right? What could have her primary care doctor have done? In this case, her primary care doctor wasn't actually a general pediatrician. Her primary care doctor was PM&R. So I'm going to say that this is a situation where a subspecialist was really managing her care. And when should the better have been done? When should that have happened? Should it have happened at 2, at 15, at 20, or a month before she came in with her pneumonia? So now what? I ask people to ask these questions. Would I be surprised if this child had less than a year to live? Is life expectancy less than normal? Do they have signs of the dwindles, which is this increasing usage of healthcare resources over a period of time? Is there distrust or conflict somewhere in the environment of people? Has someone said this family just doesn't get it? Is there unresolved pain, agitation, fear, psychic distress in the patient or family member? If any of those things are true, then I ask people to use these questions, and I'll just pass out the cards. You can carry them if you want, or you can just glance at them and toss them. It's up to you. It does still have the Michigan logo on it. I apologize. I did that a long time ago. And it's all in the timing and the approach. So consider setting aside some time, like I talked about before, intermittently or at key points in the illness trajectory to discuss quality of life, prognosis, and goals with the family. Tell the family that you want to make sure we've talked about everything openly and honestly, so that you can help them in the decision-making process as things change. Most families will not be angry if they sense compassion and honesty and forethought. Invite discussion and questions, be as open and honest as possible. Involve the children in the discussion where it's appropriate. And be prepared for initial anger and frustration. And it's often not going to be directed at you, it's going to be directed at other care providers. Speak to kids at their developmental level and offer to help parents address their children's fears as such, and avoid phrases that will confuse the issue. He needs more calories, maybe. I'm really cautious about the word need. I think it's very relative in a lot of situations. And when we say someone needs something, no parent is going to say no, unless they're very strong and very clear about their goals of care and you're not aware of them. We have to treat her UTI. It's a simple problem. Yes. But if a child is on hospice and you don't treat a UTI, there are worse ways to die than urosepsis. And I've been reminded by palliative care providers who were my mentors that you don't get to decide. If a child is terminally ill, they're going to die of a complication of that terminal illness. And a UTI is probably a complication of that terminal illness. It's not otitis media. And not to say that otitis should necessarily not fall into the same thing, but and yes, it's controversial, and yes, it's reasonable to treat a UTI in certain circumstances for comfort and for other reasons. But I was told that a child with a terminal brain tumor was hyponatremic from SIADH, and that we couldn't let her die of hyponatremia because she had to die of her tumor. I said, why is she hyponatremic? It's because she has a brain tumor. Let's be clear on the fact that she is dying of her tumor. And it's not going to be of herniation necessarily. It may be of hyponatremic seizures. And that sucks, but it may be. And what do you want us to do? So I always ask people to help set goals rather than allowing parents to just make medical decisions. You need them to say, this is our goals of care. These things are not acceptable for us in his quality of care or quality of life. And I want you to help us make decisions in that vein. And these are helpful phrases that I always tell the residents, use them with sincerity. Don't use them if they sound like they're coming out canned. Many loving parents of children with this illness might make one of many different decisions. We want to try to figure out what's right for your family. These are tough decisions. I want to make sure we've thought through each one of them with you to make sure we don't do just the next thing because we can. I hope with you that he'll get better, but I also want to make sure that in the face of things possibly not going our way, we have a plan. My job is to help you make decisions that are in line with goals that are attainable. No one is going to take away your hope, but I promise to be honest with you when we have to start hoping for different things. And my favorite, which I use with caution, particularly with adolescents, is this really sucks. There's no better word for it, and let's see how we can make it suck less. And I sort of say that jokingly, but I don't. I mean, I say that to families when we're sitting there talking about, is your kid going to die in the PICU? Is your kid going to die in the oncology unit, or is your kid going to die at home? They all suck. None of these options are good. Which one's the least sucky to you? And which one makes you think that you'll be okay 6 months from now in comparison to another. And I think that was it. Sorry. What questions can I answer?